imaging studies. The plain films, X-ray, the simple X-ray, are rarely helpful in diagnosis, but it can be benefit in ruling out other disease like GI tract perforation. Well, ultrasound and CT scans are the most commonly used imaging test in nowadays. Ultrasound, we can see the pictures about the ultrasound of normal appendix, illustrating the thin wall in coronal and longitudinal planes. But in the appendicitis cases, there is distension and wall thickening. The blood flow is increased, leading to the so-called ring of fire, not ring of king. That's the ring of fire appearance. That's very typical. Here are the imaging, CT imaging. The first image, we can see a figulith at the base of appendix, while the right image, we can see the figulith and inflammation abscess there. Differential diagnosis. Some other disease can mimic acute appendicitis, like acute gastroenteritis, gastric or duodenal ulcerative perforation, right uteral calculus, neoplasms, Meckel's diverticulum, inflammatory bowel disease, Crohn's disease, even cholecystitis. Well, for the young patient, pediatric patient, usually acute mesenteric adenitis may mimic appendicitis. That disease usually has a upper respiratory tract infection, and the pain usually is diffuse, and the tenderness is not as sharp as acute appendicitis. And the pain is not usually localized as in appendicitis. For the elder patient, diverticulitis or perforating cancer of cecum, colorectal cancer, usually mimic acute appendicitis. Well, for the female patient, the internal reproductive organs disease should be ruled out, like acute pelvic inflammatory disease, cystic ovarian cyst, or ruptured follicle. Complications of this disease, usually intra-abdominal abscess. For that patient, we give the patient antibiotics and all percutaneous drainage, then operation in 3 months. The second, internal or external fistula, rupture of the abscess and the fistula forming to the skin or intestine, even vaginal or bladder lumen. The last one is polyphlebitis. That means inflammatory amyloids entering vein system and then to the superior mesenteric vein and the portal vein system. Appendectomy. Patients who present with signs of sepsis or generalized peritonitis should be taken to OR, operating room immediately with concurrent resuscitation. Here are the pictures or demo of the operation. First, incision. Oblique incision at McBurney's point and entering the abdomen. Tracking the tinea libera, that's the anterior tinea, the most visible of the 3 tinea coli. And distally, the base of the appendix can be identified. The second step, division of the mesoappendix, ligation of the base and division of the appendix, no more than 3 mm stamp on the reserved site. The last one, placement of a pulse striking suture or Z stitch. In China, we usually call that 8 stitch. Then, inversion of the appendiceal stamp after sterilized to prevent stamp appendicitis. Nowadays, laparoscopic approach are more popular, but the procedure is usually the same. In the lap approach, we usually use the energy device to divide the appendix. Post-operative management. First, post-op care. Patients should be continued on broad-spectrum antibiotics for 4 to 7 days for complicated case, and intravenous fluid in case of post-op ileus. After the GI function recovery, the enteral nutrition can be given. Then, the surgical site care. We will talk about post-operative complications. The first, post-op hemorrhage. Then, surgical site infection. Post-op ileus and stamp appendicitis. We have mentioned that the stamp should not be over 5 mm. The remaining stamp should be no longer than 5 mm, as stamp appendicitis has only been noted in stamp over 5 mm in the literature. The last one is fistula, we have mentioned. Okay, thank you.